Welcome, everyone. My name is Elena Kidd, and I'm a program director with the University of Alabama at Birmingham School of Public Health Office of Public Health Practice. I'm very excited to welcome you to today's webinar, which is actually a double feature as part of our MDRO webinar series. Today's webinar features Ms. Amy Ward, Patient Safety Manager at Alliant Health Solutions, who will be leading the discussion on communicating critical infection prevention information among key stakeholders to improve resident outcomes, and Dr. Spencer Durham, Associate Clinical Professor of Pharmacy Practice at Auburn University Harrison College of Pharmacy, who will be presenting the fall of antimicrobials and the importance of antimicrobial stewardship. This session marks the 6th and final webinar of our MDRO webinar series. All of the past webinars have been recorded and they're available for viewing on our website, which we will drop in the chat box shortly. This webinar is made possible by the Alabama Regional Center for Infection Prevention and Control Training and Technical Assistance, or ARC-IPC. The ARC-IPC was established to meet the consultation and support service needs surrounding infection prevention and control throughout the state of Alabama. The center is a collaborative effort of the Alabama Department of Public Health's Infectious Disease and Outbreaks Division and the University of Alabama at Birmingham. The ARC-IPC provides training and technical assistance to infection prevention and control and public health professionals in areas needed to detect, respond to, control, and prevent infectious disease outbreaks. You can learn more about the center, view and listen to past trainings, webinars, and podcasts, request training and technical assistance, and view infection prevention and control resources at uab.edu/ARC-IPC. You can also email ARC-IPC@UAB with any questions. We would like to thank our co-sponsors for today's webinar, the Deep South Center for Occupational Health and Safety and the Alabama Statewide Area Health Education Centers. You can learn more about their programs and centers as a whole at the websites listed on the screen. Continuing education credits have been approved for nurses by the Deep South Center for Occupational Health and Safety for this program. In order to receive credit for this training, you must register for the training, watch the entire program, complete the evaluation following the program, and upon completing the evaluation, you will be redirected to the Alabama Nursing CEU request form, which you will also need to complete. For nurses watching live in Alabama, please submit your CEU request within 2 weeks following the live webinar. CE units will be awarded by the Deep South Center for Occupational Health and Safety. You do not have to submit directly to the Alabama Board of Nursing. For those watching on demand, a certificate will be sent to you to upload to the Board of Nursing following your CEU request form being completed. If you are not a nurse, but you need a certificate of participation, please complete the evaluation and the CEU request form, and we'll send you a certificate. CEE units for this program will expire on July 10th, 2025. If you experience any issues or have any questions about continuing education, please email arcipc@uab.edu. And finally, it is my pleasure to introduce our speakers. First, I would like to introduce Ms. Amy Ward. Amy is the Patient Safety Manager with Alliant Health Solutions. She is a registered nurse with a diverse background in nursing, microbiology, epidemiology, and infection control. She is passionate about leading and mentoring new and future infection preventionists in their career paths and assisting them in reducing healthcare-associated infections across the continuum of care. Amy enjoys spending time with family, biking, reading, camping, and running. So without further ado, it is my pleasure to turn things over to Amy.
Today, we are going to go over some communication. I know at the beginning of this series, I think we talked about infection data and surveillance and utilizing those data to make improvements. And today we're going to talk about communicating effectively with both internal and external stakeholders, both inside and outside your organization. And utilizing some standardized communication tools to structure your communications and help make sure those communications are very clear and documented. And then we are also going to discuss some key infection prevention information that's really important to communicate during transitions of care, both within the facility and as we transition to higher levels of care or back to home. So communication is included in some of the regulatory language. It is essential to improving infection prevention and control programs and to control the spread of communicable diseases, including drug-resistant organisms. So it's included in the F941 of the CMS regulations. And it states that a facility must include effective communications as mandatory training for direct care staff. The language in that really is communicating with the care team and with residents and family members. However, CDC also has their MDRO guidelines that state facilities need to implement systems to designate patients who are known to be colonized or infected with targeted MDROs, and to notify receiving healthcare facilities and personnel, that would be EMS or other transporters, prior to transferring patients within or between facilities. So this is really covered as a subset of the F880 section of the regulation that we must communicate this information with all the key stakeholders. And then also in the CDC core infection prevention practice guideline, we see that it also states that for all healthcare settings, we have a need to notify receiving facilities and transport agencies of any suspected or confirmed infections or the presence of targeted organisms. So it is really, really well covered in all of the regulations and guidelines that we must communicate effectively. We also know that communication really affects quality and safety in healthcare settings. And effective communication really is essential to achieve a high level of quality in your care and patient safety. More than 70% of adverse events are actually caused or attributed to breakdowns in communication. We also know that engaging patients, residents, and families through effective communication has a very positive effect in their emotional health. Some of their symptomology can be improved through effective communication. Their functional status is tied to effective communication. Obviously, pain control, right? If we're all speaking on the same page, and we can manage pain more effectively as well. And even blood sugar and vital signs are tied to effective communication. And we also, patient and family perception of the quality of care is directly influenced by interpersonal interactions with the facility, caregiver, and staff. So communication is really, really key to achieving a high level of quality and safety in your care. Some information about communication breakdown. So communication breaks down most often in these settings. So during patient handoffs, at shift change, when we transfer to another unit or department, when we transfer to another facility, and even within the team, there can be communication breakdown between attending providers and consulting providers, as well as between the caregivers and the patient or resident. Communication with family members as well, between the care team, the resident, and the family can also occur. And then breakdown can happen very frequently because of limited healthcare literacy as well. The most common adverse event types that occur because of communication breakdown, and as you can see, there's some infection-related ones in here. So adverse drug events related to anticoagulants is very common. Patient falls, unplanned admissions to the ICU, death, transfers to the hospital. And then here's our two big ones for that are infection-related, MRSA, bacteremia, and CODI. And we also have seen, increase in other drug-resistant organisms, and this is very likely an effect of continued breakdown in communication during transfers, whether we know they have a drug-resistant organism or not. So just to share with you a few tools that are really helpful for me and have been over the course of my practice. And I'm sure you're familiar with SBAR communication, but it's not just useful when you're contacting a provider about a change in condition for a resident or patient. SBAR is a structured communication tool that's used to communicate information in a clear and concise manner. We all know that it's used frequently to communicate changes in resident status with providers. But we can also use it to engage the family and resident in care planning or communicating the status and recommended course of actions during an outbreak or a safety event. So in my practice, I have used SBAR as a documentation and communication tool when we have urgent safety events that need to be addressed right away, or that I want to make sure I have evaluated the situation and made a recommendation, and I want to make sure that's documented to kind of cover me and as a practitioner in infection prevention. So an example of that would be, if there is an outbreak of some sort in your facility, you can compose a SBAR in written format, and then you can keep that in your files with the date and time, and send it in an email so that it's time stamped, and you can make sure that that has been documented, that your communications have been sent. So for those who are unfamiliar, I hope you're all very familiar, but SBAR is really standing for situation. You kind of give a brief overview of the current situation, whether that is a change in condition, a current concern that you may have, or another issue. Background is when you provide that relevant historical information. So test results, vital signs, diagnoses of the resident or patient, any changes in symptoms. If there's literature that you're referencing or policies that you're referencing, that's a great place to put that information. And then the assessment is your current description or assessment of the problem. What has changed? What's indifferent? What is different? What doesn't align with the policy or the literature that you're having a concern about? And then if there's any changes in those baseline labs or vital signs, for example, that's where those can be included. And then you will make a recommendation on what you think should happen, right? You're not calling the provider just to tell them all of this stuff. As the practitioner, you are telling your leadership team or the provider what you believe needs to happen. So in the case of an outbreak, you're going to say, we're going to immediately implement precautions of this nature, or transfer to a higher, if it's an airborne precaution, tuberculosis, for example, transfer to a facility that can accommodate that type of precaution. And you're stating that recommendation so that it's clear what you're asking for during that communication. And if you're speaking with a provider, they will give you that order so that you can complete that. This is an example that you can download from our website. The link is at the bottom of the page, but this is from the AHRQ, and it's another example of an SBAR tool that can be used during communication with the provider when you are suspecting a UTI. This is really helpful, and Dr. Spencer, I'm sure, will talk about some of this in his presentation as well, but we often kind of go down the road of UTI, and oftentimes we overtreat urinary tract infections. And so utilizing this communication tool will help you gather all the information that's necessary for the provider and the clinician to make a decision on whether we need to treat this urinary tract infection, or if we're going to take some other interventions like watchful waiting and rehydration. So this form really just helps you gather the most relevant and up-to-date information so that when you communicate with the provider, they have everything they need to make a very informed decision on whether they're going to treat or what they're going to do next. And in a study that AHRQ was a part of, the use of this form actually led to a 33% reduction in prescriptions for UTI that were considered asymptomatic bacteria. So just normal bacteria that's found in the urine, not an actual urinary tract infection that needs treatment. So really nice reduction just through the use of this form when communicating with providers. And of course, using less antibiotics and treating less infections that are less non-clinical things like asymptomatic bacteria will help us save our antimicrobials for when we really need them. This is another form that you can download. The link is on the slides, and they will be sent out to you after the session. And this is an interfacility infection control transfer form. So this is really useful to be used, when we're transferring to another facility. If you fill this out as best you can, or get this information in all of the data or the discharge summary that you're sending with that resident. But it's all infection related information. So it's a best practice. And I actually just watched the CDC's Enhanced Barrier Precaution webinar this morning. They posted their webinar recording from last week, and they discussed utilizing some sort of form to improve communication between facilities during transitions of care. So meet with your region care transitional care teams and figure out the best way to get this information to and from when you're transferring. You can also send copies of the most recent culture reports if those are available, but it includes like the resident demographic information, their name and date of birth, the sending facilities information, along with the unit and the nurse, physician, case manager, infection preventionist. It's nice to be able to get a hold of all of those different people if you need more information. Their current or history of transmissible organisms and MDROs, their current signs and symptoms, current precautions utilized. This may vary between facilities, of course. If you're using enhanced barrier precautions in the nursing home setting, the hospitals don't do enhanced barrier precautions, but they would like to know what you're doing, and they will likely utilize some sort of precaution for the resident when they are at the hospital. It also has a section on current or recent antimicrobial treatment, which is very helpful to know for durations, stop dates that we had expected, so that we don't just continue antimicrobial treatment for forever as we're going through these transitions. We also had some COVID-19 treatments, and then there's a vaccination section as well. So if you currently utilize some sort of form, I think there's an Interact form that's really common as well. Making sure that you also include this additional information about infections is wonderful. And it can really help reduce infection-related events during transitions of care. Some additional items that you can consider providing to the receiving facility or requesting as you're receiving residents back to you would be anything like other recent hospitalizations or encounters to the emergency department, and the reason, the care team providers, allergies, problem lists or diagnosis, medications that they're currently on, their advanced directives, immunizations, vital signs. And then some of those reports that are going to be really helpful are going to be history and physical, relevant progress notes and specialist consults, and the discharge summary. Knowing what procedures they had while they were inpatient or as outpatient procedures, lab results, including microbiology, their social history, cognitive status, and functional status. This is all stuff that is like kind of in a big packet, but tying together the infection prevention pieces will help you as the infection preventionist to really intervene early and make sure we don't have infection-related events. So this is something that I hear often from facilities, and it's everybody wants to communicate better or get more information about their patients during these transitions. I hear it from nursing homes and I hear it from hospitals when they're receiving patients. So Discussing this at your regional partnership for community health meetings or other coalitions that you have, if you have transitional care services and they kind of coordinate a meeting with the nursing homes and maybe public health and or assisted living facilities and nursing facilities, let them know that we want to improve this information. And I think everyone will say, be in agreement with you. And you can modify the tools that are available to meet the needs of the region. So if you're already using a tool, identify the information that might be missing from the infection control perspective, right? I bet they have all of that vaccination and cognitive and medication and functional status. I'm sure that's all included, but what about indwelling devices or history of MDROs that we're not aware of? You know, those kinds of things will also be important to include. During those meetings, if you're the infection preventionist kind of attending, and it really is kind of case managers at that meeting, you know, providing some case studies from your region or area can also help convey the importance and open the dialogue. So if there has been a known transmission of targeted MDROs in the area, maybe C. auris has been identified and there's been, you know, some point prevalence or some surveillance cultures happening, and we're identifying a new problem, that would be a great thing to open this dialogue and say, we really need to have these discussions. Maybe we're seeing emerging resistance within the region on our annual antibiogram updates. And maybe the facilities are seeing emerging resistance, and we want to kind of target some additional organisms. And if there's been patient harm events that have occurred, you know, I've seen CODI's result because antibiotic prophylaxis for UTI was not continued, and then a CODI happened, increased the length of stay at the hospital. So these are all preventable events that having better communication could have helped prevent that situation. And then, like I said, most facilities do want to improve communication during transitions of care. There's always more information that somebody wants who's on the care team, whether they're at the forefront or in the background, like infection prevention. So we'll go through a quick case study, and I hope y'all help me out and just put your answer into chat for me. So you're the infection preventionist in the skilled nursing facility, and you get a call from the hospital IP who states that a Staphylococcus aureus isolate has been identified, and it has intermediate resistance to vancomycin. So this is a VISA, we call it, vancomycin intermediate Staph aureus. And it was cultured from one of your residents during a recent emergency department visit. The resident was in the emergency department last week for a UTI, and the isolate was from their urine specimen. And they have since been admitted back to your facility. So they're back in their room, and no precautions or anything, but you recognize that they're also a dialysis patient. So who should you communicate this result to? Do you want to get the resident and the family, public health epidemiologist, the dialysis facility, your medical director, or all of the above? I see a lot of E's. Thank you. Thank you. Very good. So we want to make sure we communicate that with everybody that is listed. If you have anyone else that you think we should include, please drop that into chat as well. So the information that we need to communicate with each person or agency. So the patient and family, we really need to talk with them about what precautions, if any, we're going to take at the facility. And we need to talk to them about what to expect in the future. We might not know what that is, but we could just be clear and say that. Like, it's not known right now what that looks like for the future, but right now we're going to take these precautions and we'll reevaluate as we know more. And then what does the family and visitors need to do at home to be safe, right? When they come in to visit and they have to put on gown and gloves, and there's all this sign and equipment outside the room, they're thinking, maybe my loved one was at home last week and now they're here and we're doing all this equipment and all this stuff. And they're wondering, do I need to clean my house different? Do I need to use bleach or a special cleaner? Do I need to wash the laundry and the sheets different? What does that mean when they come home? If we're planning to bring them home soon? What about the grandkids? Is there risk to the grandkids? Like they have all these questions in their mind. So they want to know what should they do at home as well. And again, if that's unknown, or you need to maybe consult with public health epidemiology, they can help you with that information as well. You definitely need to report to public health. This is a reportable condition, and you're going to provide the demographics, history and physical, the dialysis facility information if you have that, and the lab result through the REDCap link that's on there for Alabama. You also want to inform the dialysis facility so that they can take appropriate precautions. They, again, may not know what that means for their facility, but you can encourage them to reach out to public health so that they can connect those dots with them. They may need to take precautions during treatments and connect with public health. Your medical director and you can talk about the precautions to take in the facility, whether that's probably going to be enhanced barrier precautions or contact precautions, and kind of discuss what's the risk to others in the facility and how to mitigate those risks. And the medical director may also, want to contact infectious disease at their discretion to kind of have those discussions as well. And then, of course, the hospital IP is great to be in contact with so that you can get additional records or results that might be helpful to you. And then they can probably assist you with any resources or recommendations in conjunction with the public health department. Very good. All right, so documenting communication. If it wasn't documented, it wasn't done. So we want to make sure that the resident and family, maybe you're providing them with a brochure or a flyer about MRSA and talking about how, the vancomycin intermediate resistance is kind of like a step above or a step worse than MRSA. And you can let them kind of teach back so that you can assess their understanding. And then document that in their medical record, who was present and how they understood that information. For public health, you'll want to make sure that you save that email confirmation from your REDCap report card. And you can keep a file, or if you have surveillance software, you can link that PDF into the infection event information. And the dialysis, maybe, document who you talked to and the date and time in that medical record so that that is closed and documented as well. And I have another quick case study for you. So you're the IP at the local skilled nursing facility and you received this lab report for a sputum culture that was collected from one of your residents last week. They did transfer to the hospital yesterday and they're currently admitted. So what concerns or follow-up questions do you have about this isolate? And just put into chat what you're seeing. These are all real cases that I've been a part of. So anyone have anything to add in here? What are you concerned about when you see this report? Carbapenem resistant, Pseudomonas aeruginosa. Awesome, Amber, great. Yes, that is one thing. And there's one more thing that I am concerned about as I see this. And it's down at the bottom in the MICs. Not really susceptible to TOBRA. Okay, and I'm concerned about thank you, Dr. Durham. I'm concerned about the imipenem resistance here, okay? So I wanna know, the drug resistance part is great, but I wanna know if this imipenem resistance is carbapenemase producing or just carbapenem resistant, okay? And then who should you report this result to? The state. Awesome. Good job, Amber. So we're going to get it to public health. This is not listed as an organism on the Alabama reportable conditions list. This is going to fall into the category of a case of public health importance. So my mantra with this sort of thing is, when in doubt, send it out, okay? If you're looking at it and you're going, that kind of looks like an ugly bug and I don't like it, just send it out, even if it's not listed on there. If If the state doesn't like it, they can just toss it and file it appropriately into the trash bin. But you did your due diligence to let them review it and investigate it and file appropriately. So when in doubt, send it out, even if it's not listed on that list of organisms. The case of public health importance is kind of, I'm like, I'm going to lump this in there and report it. So we definitely want to make sure that we're looking at that imipenem resistance and getting help with that. We also want to let the hospital IP know, right? Because now this resident is admitted to the hospital, and we have this important result, and we want to let the hospital IP know, probably fax this over to them so that they receive that as well, and they can make the determination for precautions to take in the hospital. So again, what information does each person need? It's a reportable condition, so you're going to fill out that red cap report card and save that confirmation email to your records. You're going to provide the lab report and any additional results that you have about this resident to the hospital IP so that they are aware. They may be waiting on their own culture results, so they may not know yet that this is happening, and it will help them contain this drug-resistant organism at the hospital early, right, rather than waiting for their own cultures to come back. You'll need to talk to the medical director about if there's need for additional case finding, or if this is kind of maybe potentially a transmission, what could the source have been? You might need to do some case finding. And then you'll also want to discuss with the resident and family. Because the resident is currently inpatient at the hospital, you can coordinate with the hospital IP to kind of find out what they've discussed already, if anything, with the resident and family. And then you'll want to continue communication with them once they return back to your facility. Along those lines, precautions may be different at the hospital versus the skilled nursing facility, right? The hospital may have them in droplet precautions. They might be ventilated and, or, you know, because it's a sputum culture, they may be unable to contain those secretions. So the hospital may actually have them on droplet precautions or contact precautions. And you, when they arrive back, they may be on enhanced barrier precautions. So that's good information to communicate with the family and the residents. Precautions may look different at the different facilities, and there's some reasoning behind that you can explain. So during transitions of care, this is just all of these tips are going to help you set those communication expectations with the facilities that you're transferring to and receiving patients from. Having open dialogue with the receiving facility as near to the time of transfer as possible. I know that it's hard to get rapport between the nursing staff at the hospital and the nursing staff at the skilled nursing facility, but that open dialogue and communication is really important. So even if it's just the nurse's name and extension at the hospital, so that the nurse at the skilled nursing facility can get in touch with them if they have any questions when they arrive. Discussing any of those current signs and symptoms of infectious disease or infection, pending or recent culture and sensitivity reports, other pertinent tests or invasive devices. Again, those current medication lists, including antibiotics, and the reason for those medications. And then whenever a communication breakdown occurs or there's missing information, it's helpful to do a root cause analysis so that you can kind of trace back what happened and then hopefully make an improvement on that communication. So an example would be a resident who has recurrent urinary tract infections and an indwelling Foley catheter transfers from the skilled nursing facility to the hospital. The medication list wasn't accurate, and the urinary tract infection prophylaxis wasn't prescribed at the hospital. So then that resident ended up having a CAUTI in the hospital. They had an increased length of stay and additional treatment that could have been prevented by continuing that medication.
Thank you so much, Amy. That was a wonderful presentation and learned a lot about the importance of communication, or just a good reminder of the importance of communication and how beneficial it is for patient health.
Yes, thank you so much for having me.
It is now my pleasure to introduce Dr. Spencer Durham. Dr. Spencer Durham is an associate clinical professor in the Department of Pharmacy Practice and also serves as the Director of Alumni and Professional Affairs with the Harrison College of Pharmacy. Originally from Arab, Alabama, he completed his pre-pharmacy coursework at Auburn University and graduated with his Doctor of Pharmacy degree from the Harrison College of Pharmacy in 2007. He went on to complete an ASHP-accredited postgraduate residency at Children's Health Systems in Birmingham, Alabama in 2008. Dr. Durham has published more than 20 peer-reviewed articles in respected journals and several book chapters. He is an active speaker each year at national, state, and local conferences where he educates healthcare professionals on topics related to infectious diseases and antimicrobial stewardship. So it's now my pleasure to turn things over to Dr. Spencer.
I'm very excited to be able to talk to you about antimicrobial stewardship. It is certainly one of the areas that I am most passionate about. I currently have a project that I am doing with the Alabama Department of Public Health called Improving Antimicrobial Stewardship Across Alabama. And so I'm doing this presentation kind of as part of that project. But certainly antimicrobial stewardship is extremely important. In the state of Alabama, we do have high resistance to certain organisms, and or certain organisms have a lot of resistance to different antimicrobials. And so I'm going to go through the history of some of that and then really just talk about how important antimicrobial stewardship is to combating some of that resistance. First, I just wanted to mention that I do not have any actual or potential conflicts of interest related to this program. In terms of our objectives, I do want to go through a bit of the history of the development of antimicrobials and how bacteria have become resistant to those antibiotics over time. We'll also talk about exactly what antimicrobial stewardship is, and then discuss how antimicrobial stewardship helps to hinder the development of antimicrobial resistance. And I always like to give this quote when I am talking about antimicrobial stewardship. If we were in a classroom setting, I would actually ask who knows who Sir Alexander Fleming is. If anyone wants to put that in the chat, you can feel free. But his name is probably familiar to you, even if you can't place exactly who it is. Alexander Fleming was one of the gentlemen who is credited with the discovery of penicillin. There were two different groups who were generally credited with that discovery, and he led one of those groups. And he, as well as the other people who were credited with discovering penicillin, won the Nobel Prize. I don't remember which year they won that in, but they won the Nobel Prize that year. And after he won that very prestigious honor, he was giving an interview. And in that interview, he made this statement, and this statement has always really stuck with me. And he said, "The thoughtless person playing with penicillin treatment is morally responsible for the death of the man who succumbs to infection with the penicillin-resistant organism. I hope this evil can be averted." So when Alexander Fleming made that statement, penicillin was really the only commercially available antibiotic. And I think it was very forward thinking of him because he actually realized that people were going to misuse penicillin. And because of that, the resistance was going to happen. Even if it hadn't really happened yet, he recognized that there was the potential for that. And again, I think that was very forward thinking of him because unfortunately, what he predicted has really come to pass, and we'll go through that a little bit further. Just some general information I wanted to mention, and this overlaps a little bit with what Ms. Ward was talking about in the previous presentation, but certainly, not just in Alabama, not just even in the United States, but on a worldwide scale, multi-drug resistant organisms are increasing at a very alarming rate. They are thought to contribute to about 2 million illnesses and about 23,000 deaths in the United States annually, and that number is probably a little bit undercounted. So certainly this is a very serious problem that we're dealing with. In May of 2016, colistin-resistant E. coli was first reported in the United States, and many of you probably are familiar with colistin, or at least have heard of it. I will tell you that when I was in pharmacy school, we never talked about colistin. I did not know what colistin was until I was a resident and I was treating a cystic fibrosis patient who had a really resistant organism, and we had to use colistin to treat it. But the reason that we didn't really talk about it when I was in pharmacy school is that it just was not used at that time. I can tell you now we do talk about it in pharmacy school because unfortunately resistance has become such a problem that we are having to use drugs like colistin, which is actually a very toxic drug, and so that's why it kind of fell out of favor for being used. But unfortunately, now we do have to use it again. And again, in May of 2016, we actually had the first case of colistin resistance that was reported in the United States. And certainly the misuse of antimicrobials is the major contributing factor to the dissemination of antimicrobial resistance. There are certainly a lot of factors that play into it, but misuse of antibiotics is certainly the biggest factor. There is a high cost to multi-drug resistant organisms. It's thought to cost somewhere between about $20 to $35 billion annually. So certainly a significant financial strain on the healthcare system. From a clinical standpoint, it costs about 8 million extra days in the hospital per year. And so again, that's certainly a very significant clinical problem for direct patient care. It's estimated that at least 30% of antibiotics that are prescribed in the outpatient and the emergency care settings are just simply not needed. So in other words, someone comes into one of those settings, they are given an antibiotic. 30% of the time, they should never have been given antibiotic, at least 30% of the time. In the inpatient or the acute care setting, about 20 to 50% of antimicrobials are prescribed either unnecessarily or inappropriately. So somebody may just not need an antibiotic and are prescribed an antibiotic, or they may require an antibiotic, but the antibiotic that they have been prescribed is inappropriate. It's either not the best antibiotic for the infection that they have, or the antibiotic is not dosed correctly or something like that. And we'll talk a bit more about that later in the presentation. I wanted to just sort of put an example of some of the things that we face with antimicrobial resistance. And if any of you are not familiar with this report, it was a report that was issued by the Infectious Diseases Society of America in 2017 called The Faces of Antimicrobial Resistance. And it details 13 different specific cases of patients who faced life-threatening antimicrobial resistance. And the goal of this publication was really just to highlight how resistance affects individuals, their family, their friends, and really just society as a whole. And so I wanted to go through one of the examples that is in this report. There was a patient whose name was Catherine Duff. She was diagnosed with severe diverticulitis, and she required surgery to remove about 1/3 of her colon because of the diverticulitis. After her surgery, she developed an abdominal abscess, which burst. That required further surgery, and she ultimately experienced sepsis due to methicillin-resistant Staph aureus. The antibiotics that was used to treat her sepsis caused a Clostridioides difficile infection. She subsequently had a total of 8 different episodes of C. diff over a number of years. But with each episode, it was just becoming more and more worse, and it was taking her longer and longer to recover. At one point, she experienced up to 30 different diarrhea episodes in a day. She became bedridden and lost almost 70 pounds. And eventually, she was told that she just would not survive, that there was really nothing more medically that they could do to help her. At the time that she was told that, something called fecal microbiota transplantation, which is basically taking healthy stool from a person and transplanting it into someone who has C. diff. That's, as you all, I'm sure, know, that's something that is not uncommon for us to do now. But when this first happened to Ms. Duff, the fecal microbiota transplantation was really in its infancy and it was not used clinically. However, Ms. Duff and her husband had read about it, and they elected to perform an FNT at home. I don't know how they did that. The report does not go into that. But they did that at home because they had just read about that it was something that kind of a long shot of something that might work. She actually had a very significant improvement. She improved quite rapidly with her symptoms as a result of this. Now, unfortunately, she had a subsequent surgery that caused another C. diff, a resistant C. diff infection. By that time, FMT was more of a clinical tool that we could use. And so she had another FMT that was performed via colonoscopy, had great success with that. And to my knowledge, did not have any further C. diff episodes. And she ultimately started the Fecal Transplant Foundation. So I just wanted to use this example because I think it very nicely illustrates how antimicrobial resistance and use of antibiotics can really cause very significant problems with patients. Miss Duff's story, really kind of has a happy ending associated with it because she ultimately got better and was able to start this foundation, which still exists today. But if you actually go to look at that Faces of Antimicrobial Resistance report, not all the cases they talk about end happily the way hers did. There's a number of patients who ultimately died from their resistant infections. So, having looked at that example, I'd like to go through just some of the history of the development of antimicrobials and the history of how antimicrobials resistance developed in relation to the development of antibiotics. I already mentioned penicillin, which was the first antibiotic that was marketed for commercial use. It was actually discovered in 1928, but it first came into large-scale production in the early 1940s. As you can probably surmise, the reason that it really went into large-scale production was because of World War II. There were a lot of soldiers who were dying of infections in the battlefield. If they survived, a gunshot wound or whatever it was, they were dying of infections. And so penicillin really came into widespread use at that time to treat injuries from World War II. But the advent of penicillin really revolutionized the treatment of infections. Prior to the discovery of penicillin, if someone had a really severe infection, it was unfortunately very likely that they were going to die from it because there was really just not a lot of treatment options. So the development of penicillin really served to usher in what I like to call the antibiotic era. The subsequent decades really saw a lot of development and discovery of new antibiotic agents, and we'll go through some of that. However, before we get into that, I do want to point out that when penicillin was first discovered, Staph aureus isolates were sensitive to penicillin, at least the vast majority of them were. Just within months of the introduction of penicillin, isolates of Staph aureus started to produce a beta-lactamase. By the late 1960s, about 80% of community and hospital staphylococcal isolates were resistant to penicillin. And today, virtually 100% of Staph aureus isolates produce a beta-lactamase. And I just like to point that out because you see clearly, even within just a very brief period of time to the introduction of penicillin, bacteria started figuring out how to become resistant to it. So if we move on and look at the era beyond the discovery of penicillin, the 1950s to the 1970s are sometimes called the golden age of antibiotics. There were a lot of new antibiotic classes that were introduced into the market. The cephalosporins came out, vancomycin, doxycycline, drugs that are still used clinically today were found during this period of time. In 1964, a doctor named Maxwell Finland, who was a very famous doctor and researcher with infectious diseases at the time, he also, kind of like Sir Alexander Fleming, really recognized the dangers of antibiotic-resistant bacteria, and he started warning that overuse of antibiotics was going to cause some organisms to become resistant. And in fact, he made that warning first in 1964. In 1965, the first cases of penicillin-resistant pneumonia or Streptococcus pneumoniae were reported. In 1968, we actually had the first reported case of MRSA that was reported in Boston. Even to this day, I'm sure as everyone is aware, we have a very significant problem with MRSA. In the 1970s and 80s, there were more than 60 new antibiotics that were discovered. However, many of the antibiotics were not novel classes of antibiotics, but they were modifications of existing classes. So, for example, some cephalosporins already existed in this time period. These cefamycins, so drugs like cefoxitin and cefotetan, were discovered and brought to the market. Minocycline, the carbapenems, and some fluoroquinolones were first discovered during this time period. In 1988, we had the first case of vancomycin-resistant enterococcus that was first reported, and I know Ms. Ward talked about vancomycin intermediate. I think hers was Staph aureus, but this is enterococcus. But certainly, we still see vancomycin-resistant enterococcus to this day, and in fact, it's becoming even more prevalent with every year that passes. In the 1990s to the early 2000s, there was really a dramatic decrease in the number of antibiotics that were being developed. And I think that's for a couple of different reasons. One is that there was this belief that most of the novel agents that were going to be discovered had already been discovered, that there really wasn't a lot of incentive to look for new agents because they just weren't going to find them. I'm not sure that that's completely true, but that was at least the prevalent belief at that time. And I think importantly to point out, there was less financial incentive for drug companies to develop new antibiotics. And so the example that I always give my pharmacy students and the medical students and the medical residents that I teach is that if you look at it from the perspective of a drug company, if they develop a drug to treat something like hypertension or diabetes, there's a lot of financial incentive to do that because those drugs are potentially going to be used for many years, in some cases for someone's lifetime. So they're going to get a lot more return on investment from a drug that's going to treat a chronic condition than they are from an antibiotic that's going to be used, for maybe 7 or 10 days or something like that. And so because of those reasons, during this time period, there was a very dramatic decrease in the antibiotics that were discovered. Now, having said that, in 1996, levofloxacin was first introduced to the market, and we certainly still use that drug today. However, just within the first year of it being introduced to the market, we started seeing reports of levofloxacin resistance. So again, resistance does develop very rapidly when a new drug is brought to the market, and we've seen that repeatedly. In 2004 and 2005, Pseudomonas and Acinetobacter isolates were first discovered to be resistant to all commercially available antibiotics. And what I'm talking about here is that these were kind of discovered in the lab. They weren't really discovered in a patient who actually had an infection, but we started seeing these isolates being discovered. In 2008, the New Delhi metallo-beta-lactamase was first discovered, which is actually a carbapenemase, which was mentioned in Ms. Ward's presentation as well. That confers resistance to all beta-lactam antibiotics. And I think something that often gets missed when we talk about carbapenemases is that you typically think about just the beta-lactams being inactivated, but unfortunately, those bugs that produce carbapenemases also have a lot of other resistance mechanisms. And so when you see something that produces a carbapenemase, they also have virulence factors that are going to inactivate things like the fluoroquinolones and a lot of other drug classes as well. In 2012, there was a very famous reported outbreak of carbapenem-resistant Enterobacterialis, or CRE, that was reported from duodenoscopes that were not thoroughly cleaned. In 2016, the first mobilized colistin resistance gene was discovered for the first time in the US. I think it had been discovered previously worldwide, but it was the first time that we had actually seen it in the United States. And then in 2017, there was a case that was in the news media quite prevalently at that time, where there was a patient in the US who died from a Klebsiella pneumoniae infection that was resistant to all of the commercially available antibiotics in the US. And that was the first time that had really been publicized to any significant extent. So I want to point out that in around 2013, we were seeing a lot of these more resistant cases of antibiotics being reported. The CDC issued a report called Antibiotic Resistant Threats in the United States. And the purpose of this report was to really kind of quantify and separate the pathogens that the CDC thought were of most concern in the United States. And so they made 3 different categories: the urgent, serious, and concerning categories. And I wanted to just briefly go through those and show what organisms fall into which category. So the urgent threat, which was the most severe of the threats that they developed, for a bug to be classified as an urgent threat, it had to have the potential to become widespread. It was associated with serious risk, and it was something that they felt required an immediate public health attention. So there are 3 different bugs that fall into that classification. One is Clostridioides difficile, carbapenem-resistant Enterobacterialis, and we've seen examples of those already. And the third one might be a little bit surprising, but it is resistant Neisseria gonorrhea. We could have a whole presentation about how Gonorrhea has developed resistance over the years, and we are unfortunately seeing a lot of resistance with that particular organism and a lot of difficulties with treatment. And certainly that's a bacteria that has the potential to become very widespread. And so that's why it was put into this urgent threat category. The serious threat, which is the second level of classification, for an organism to be put in this category, the incidence of infection might be decreasing and there might be some therapeutic options available, but very close public health monitoring was required to prevent them from becoming an urgent threat, so into that most severe category. There are 12 different pathogens that were in this classification, and these are things that I think we would likely see very commonly in clinical practice. So things like MRSA, VRE, resistant strep pneumo, resistant tuberculosis, Shigella, Salmonella, Campylobacter, multi-drug resistant Acinetobacter, and Pseudomonas. We don't see those quite as commonly, maybe as some of the others, but when we do see them, they're extremely difficult to treat. I know, at least in my practice, I unfortunately do see a lot of multi-drug resistant Pseudomonas, less with Acinetobacter, but those are just very hard organisms to treat. If I were giving this presentation, 10 years ago, I would tell you that I don't see much ESBL producing organisms. Now, it's virtually every week, at least every other week, I have at least one ESBL producing organism that I see in a patient. So certainly much more common than they were, many years ago. And then we also put fluconazole resistant Candida into this category as well. The concerning threat, which is the least severe of the concerns, these organisms is where resistance is fairly low, or there are several treatment options available, but they can still cause severe illness. So this would be something like vancomycin resistant Staph aureus. And again, in Ms. Ward's presentation, she talked about a vancomycin intermediate Staph aureus. Certainly we see those as well. Erythromycin resistant group A strep, and then clindamycin resistant group B strep. Those are the three that fall into this category. So I think the CDC did a really good job of trying to quantify and categorize the organisms that really are of most concern in the United States. The World Health Organization has a very similar list. The categories are a little bit different, and they classify organisms slightly differently, but it's very similar to the CDC's classification. So having gone through all of that, I'd like to spend the last part of our time talking about antimicrobial stewardship, because as you'll see, antimicrobial stewardship really is the best weapon that we have to try to combat this increasing antimicrobial resistance. So we look at what the definition of stewardship is. That is the activity or job of protecting and being responsible for something. Antimicrobial stewardship involves taking responsibility for the management of antimicrobials with the goal of using them most appropriately. I do want to point out that there is not, one single person who's going to be responsible for this. This really is multidisciplinary. Hospitals may have an antimicrobial stewardship nurse or an antimicrobial stewardship pharmacist who may, lead and kind of oversee the efforts, but the efforts really are multidisciplinary. It involves, nurses, physicians, pharmacists, other healthcare providers are really all essential to providing appropriate antimicrobial stewardship. The Infectious Diseases Society of America does have a specific definition of antimicrobial stewardship. They say that it is coordinated interventions designed to improve and measure the appropriate use of antimicrobials by promoting the selection of the optimal antimicrobial drug regimen, dose, duration, and route of administration. I think sometimes all of these things get a little bit lost when we talk about antimicrobial stewardship. A lot of people think, oh, well, it's just using the correct drug, or it's cutting down on the use of broad spectrum drugs. And certainly those are very important things. But we also really have to think about, maybe it's the correct antibiotic, but is the dose correct? Does the patient have a correct duration of therapy? One of the things that I always teach my students is that the perfect recipe for a bug to develop resistance is to give a really low concentration of the drug over a prolonged period of time. If that happens, you are basically telling the bacteria how to become resistant to that particular antibiotic. So in my practice, when we're dosing antibiotics, in general, we really want to give the upper end of the dosing regimen. That is very different from other disease states. If you think about a patient who is just diagnosed with hypertension and we're going to start lisinopril as treatment for them, we are not going to start at the highest dose of lisinopril. We're going to start at a lower dose and gradually work our way up to a higher dose. That is the exact wrong thing to do with antibiotics. You do not want to start low and go slow. You want to hit them very hard up front with higher doses, still safe doses, but higher doses, because we know that the lower amount of a drug that of an antibiotic that you give, the more likely the bacteria is to develop resistance. So dosing and durations of therapy are a very important part of antimicrobial stewardship. The IDSA goes on to say that essentially the goal of stewardship is to achieve optimal clinical outcomes related to antimicrobial use, to minimize toxicity and other adverse effects, to reduce healthcare costs related to infections, and ultimately to limit the selection of antibiotic-resistant organisms. So if we look at what does antimicrobial stewardship encompass, there are a number of different strategies, and this, what I have on the slide, certainly is not all encompassing, but I think these are some of the most important things to think about. Limiting the inappropriate use of all antibiotics. The most classic example I can give is not prescribing antibiotics when an infection is likely viral. So for example, an upper, respiratory infection. We know that those are almost always viral. They can be bacterial, but the percentage of cases that are caused by bacteria is very low. But if you think about the number of patients who go into an outpatient setting with an upper respiratory infection, how often do they get an antibiotic? It's very frequently. One of the things that we're kind of coming out of is, COVID infection. At the height of COVID, I can't tell you how many people I saw who were diagnosed with COVID, had no evidence of a secondary bacterial infection, and the patient was given azithromycin. There is just no evidence to support that, and you're essentially overusing a drug with no purpose. There was no bacterial infection, so the drug is not going to help you. So I think that really is probably the most important thing as we think about antimicrobial stewardship, but there are certainly other things as well. Utilizing narrow spectrum antibiotics, using oral antibiotics when you can. So someone who's in the hospital who's getting IV at the appropriate time, switching them to an oral antibiotic is a very important part of antimicrobial stewardship. Decreasing actual or potential adverse effects. We've talked about C. diff a little bit. We know that C. diff is a complication of using antibiotics, and so decreasing the incidence of things like C. diff certainly is important. Renal dose adjustments, making sure that a patient is getting a safe dose of an antibiotic, for example. And then, as I mentioned on the previous slide, cost effectiveness is certainly important to antimicrobial stewardship as well. If you look in the literature, and for the sake of time, I'm not going to go through the different studies that have looked at antimicrobial stewardship, but we've clearly seen that good antimicrobial stewardship improves patient outcomes. It decreases adverse effects. There's it's clearly been shown that antimicrobial stewardship can decrease the incidence of C. diff infections, improving the rates of antibiotic susceptibilities to targeted antibiotics. A good example that I think of that is decreasing fluoroquinolone use. In the state of Alabama, we have very high resistance to the fluoroquinolones. And there are studies that look at when you limit your use of things like the fluoroquinolones over time, you're going to start seeing some of that susceptibility return. And so that's a very important part of stewardship. And really just optimizing your resources across the continuum of care. We know that if someone is in the hospital with a multi-drug resistant infection, that's going to translate to eventually the person being in the outpatient setting, and you've got the potential to spread, the infection that way. And so when you think about antimicrobial stewardship, it's really important to think about the whole, comprehensive picture of the way that we utilize our resources. There are a number of different resources that are available to help guide stewardship activities. I'm sure everyone who's on the call is familiar at least with some of those. The CDC has issued guidance for providing antimicrobial stewardship in the hospital setting, the long-term care facility setting, and the outpatient setting. If you look at historically, when we think about antimicrobial stewardship, most of the stewardship activities have been done in the inpatient setting, so in the hospital setting, the acute care setting. But the need to provide that in other areas is very quickly rising. And I think that Ms. Ward did an outstanding job of talking about, good judicious use of antibiotics in the long-term care setting. We're very quickly realizing that there's a lot of misuse of antibiotics in the long-term care setting and in the outpatient setting. A lot of resistance that we're seeing now to some antibiotics is really being driven by misuse in the outpatient setting. I mentioned azithromycin, previously. We're unfortunately just across the United States seeing a lot more azithromycin resistance. And that is driven, very, very majority, how do I want to say it? Like the majority of that resistance, I guess, is being driven by misuse in the outpatient setting, prescribing azithromycin when there really is just no indication to do that. And so we're starting to see that, good stewardship activities in the outpatient setting as well is very important. And so the CDC has tried to provide some guidance for that. I think providing stewardship in the hospital setting and the long-term care facility setting is very similar, but the outpatient setting has certainly, very unique challenges. So for example, in the hospital setting or the long-term care facility setting, we could actually, limit by policy our use of certain antibiotics. I mentioned fluoroquinolones previously. There's a lot of data in the medical literature where different institutions have implemented fluoroquinolone restrictions, and only providers are only able to get fluoroquinolones for use in certain clinical situations. That's certainly easier to do in the hospital and long-term care facility setting, whereas in the outpatient setting, it's a lot more difficult to do that. So really, we have to focus on education in the outpatient setting. So certainly every area has its own unique challenges when we're talking about providing antimicrobial stewardship. So just to recap here at the end, I want to leave a couple of minutes for questions if anyone has anything, but we are seeing much more antimicrobial resistance in the United States as well as on a worldwide scale. There's a limited development of new and particularly novel antibiotics. The antibiotics that have come out in recent years are not particularly novel. They're sort of modifications of existing antibiotics. They're still certainly very useful, but they're not particularly novel, at least in most cases. Antimicrobial stewardship really is the best tool that we have to helping stop or reversing antimicrobial resistance. And stewardship encompasses a number of different aspects that we've just gone over, but primarily it's used to decrease the use of unnecessary or inappropriate antibiotics and promote the use of more narrow spectrum antibiotics, at least when it's appropriate. That's really the end of my presentation. I'm happy to take any questions if anyone has anything. I can put my email in the chat as well if anyone thinks of anything later. Be happy to talk with you about anything related to ID or antimicrobial stewardship.
Thank you so much, Dr. Durham. We do have one question that kind of ties into something you were mentioning earlier about antimicrobial stewardship being multidisciplinary, but how do you kind of, I guess, gain buy-in in your facility? So any advice on how to deal with an MD or a nurse practitioner who may not practice antibiotic stewardship, despite giving them, information from the CDC, other education, kind of what else can be done to help get their buy-in?
That's a really great question. And I certainly don't know that I have the best, answer to that. I would say a couple of different things. One, with some providers that I've worked with who I've had that problem with, time and persistence, really does help. Continuing to educate them, continuing to, give specific examples. Like if I have a provider who is resistant to, cutting back their use of certain antibiotics. I will take individual patient cases and show them, where we could be more judicious with our use of antibiotics. And over time, I think sometimes that does, work. Sometimes it doesn't. I think in those cases where, it doesn't work, when education alone does not help, I think if you're in an institutional setting, like I was mentioning previously, in a hospital or a healthcare system or a long-term care facility, implementing some of those processes where you can restrict the use of antibiotics can really help with that, to make it to where a prescriber cannot prescribe an antibiotic except in certain situations. Now, you may get a lot of pushback from that, and you probably will, but ultimately it really will help. And there are lots of examples in the literature of where that has happened and where it has really cut down on the use of certain antibiotics.
Thank you so much for presenting today. Such an important topic that needs to be discussed. And thank you everyone to tuning in. Just be on the lookout for additional webinars that they're going to be sponsored through the ARC IPC, and you should be getting an e-blast on those once they are scheduled. So thank you everyone, and I hope you guys have a great rest of your day. Thank you.